Quickly, I have no disclosures. The general objectives of the talk are as thus. First, I think it's really important that we review basic cardiac anatomy and specifically how the heart sits within the body, and then some quick ultrasound principles, including how we manipulate the probe. And from that, we'll go into all the views, figure out what we see in each of those views, and then try to describe the utility of those views and the information we can get in each one. So quickly, or maybe not so quickly, cardiac anatomy. I thought this was really important because I did a whole critical care fellowship, but I never realized that the heart didn't sit in the body the way that I thought the heart sat in the body, which is what I thought on the left. So I used to think that the atrium were a superior structure and the ventricles were inferior. But really, and we all know this because we put our hands on the left side of our chest when we're saying the Pledge of Allegiance, we know it's on the left. But it's on the left because it is both rotated on a y-axis, which is why it's levocardic, but then it's also tilted upward on an x-axis. So it kind of lies more horizontally than you might think that it does. So in actuality, the heart sits in the body more like the figure on the right. And this is important because when you think about how you're imaging, the planes that you're getting, when we talk about peristernal long axis, the long axis of the heart is the red arrow. And the long axis of the body is the blue arrow, and they are not the same, right? They are definitely askew from each other. And unless, again, you understand that, then the views that we're trying to get are not really going to make sense to you. So given that the heart is sitting in the body as it is, your atria are actually not superior, but really more posterior structures, and the ventricles are the anterior structures. And since it's rotated in the body, your right side is going to be what's in the front and your left side's in the back. So the most anterior structure in the heart, or in the heart of the heart in the body, is going to be your RV, which is what the surgeons see when they do the sternotomies and open up the chest. And then the most posterior structure is going to be your LA. And then in terms of where the valves sit, those are also a little bit tricky, but you have your AV valves, your mitral and your tricuspid, and then your semilunar, and they sit kind of apart from each other like this. And I feel that the best way to visualize this is to take an x-ray of somebody who has 4 prosthetic valves and just try to see where they are. So if you can see my arrow, the tricuspid valve is right here. So it's on the spine, which is important even when we're thinking about things like when we're doing line placement, right? We do our RA, our SVC RA junction here. But when we get down to here, everyone's like, oh, it's in the RV, but the RV doesn't start until after the tricuspid valve. So technically this is the RV and this is the RA. I just think it's good, grounding for yourself. This is the tricuspid, this is the aortic, and this is the pulmonary valve. So again, trying to get a sense of where these different structures are within the chest cavity gives you a better idea of where you're trying to place your probe. So moving on to some quick review of just ultrasound physics and then how to optimize our image. In terms of your probe choice, you guys should know at this point there are 3 probes that we typically use. My preferred one is the phased array, but I will take a curvilinear, which is what people typically do for abdominal exams, if your curvilinear probe has a small footprint. And that's important because I think some of the difficulty that we have when trying to obtain these images has to do with getting in between rib spaces. So if the footprint of the probe is huge, like those giant abdominal curvilinear probes, you're not going to be able to get the image. Other important points that you should take for yourself when you're doing your scans is you really need to fill the frame. And this gets back to what Sam was talking about when he was going over ultrasound physics, which is that time and distance are directly related. So the less time that you spend, it means that everything comes back faster. And if ultrasound probes spend about 1/3 of the time sending and 2/3 receiving, the faster you receive those waves back, the more resolution you're going to have. So the way to enhance that is that you make the distance as little as possible for what you need. So your frame, whatever you're looking at should fill the whole frame instead of having a lot of black space at the bottom. And this will mean that you have better frame rates, which means better resolution. Also, if you can, our machines can't, but if you can take down the frame width, it does the same thing, right? You get more waves back faster, which is better resolution. Similarly, if you can change your focal depth, we can't on our machines, then I would do that. And then just some key points to remember that in ultrasound, the 2D structures and the Doppler structures end up being not usually accessible from the same view. And that's because 2D structures are best visualized when the probe or the wave is hitting it perpendicularly versus velocities, which you want when it's going parallel to your probe. Okay, so this I think probably is most important because if we're going to talk about how to optimize images, we need to be able to use the same language and the same vocabulary. And this goes to when like we're teaching right at the bedside, when I'm telling you, do this to get a better view, we need to use, again, the same language. So I made a makeshift probe. It's a hand sanitizer bottle, but there is an indicator here, and then the cap will be like the cord. So the four terms that I use most frequently are rotate, tilt, slide, and rock, and we just have to go over them really quickly. Rotating is probably the easiest one to understand. It's where you take the probe and you just turn it in the same plane, the same like Z plane. So the footprint, which is what I've tried to illustrate here on the left, doesn't change in terms of the amount of surface contact there is between the probe and the patient. It just changes essentially in orientation. Tilting, on the other hand, is you take the probe and then the tail, and you move the tail either in one direction away from the patient or towards the patient's head. And this is tilting or sweeping. And if you look at the footprint, you'll see that because I'm cutting it on, this is blurring because, okay, great. Because I'm tilting it on this long axis, right? The amount of surface contact that the probe has with the patient is changing, and it actually means there'll be less contact, which is important because if you don't have enough gel, then when you're doing something like this, then the probe comes off in terms of contact with the patient, and you won't get good imaging unless you have a medium through you interact. So you have to have a lot of gel. Sliding just means that you take the probe and you move it again, all in the same plane, but not changing the rotation around a y-axis, but just moving along the same plane. And then rocking is moving in the direction or away from the direction of the probe indicator. So there are variations of the same thing, but again, important for everyone to have a unified vocabulary. And then lastly, before we get into the individual views, I just think it's also important to recognize that PoCUS is not the same thing as echo. In general, obviously PoCUS is a much faster and more like rudimentary exam. It's really used to assess things like function and infusion versus echo, where you have like 100, 200 clips and you're going into like deep congenital like views and trying to get basically more information. The echo machines, typically, unless you're using things like MindRays or like some of the GE machines, are also going to be more technologically advanced, which means you get higher resolution and higher and better pictures. You also have a lot more different probes, right? We use like 5 different probes just for echo among the different ages and sizes of patient. Whereas in PoCUS, we use 1 probe and we just use it for all the patients. And you have, again, because of the technology, better ability to adjust your picture. And then echoes are also read by attending cardiologists. So if you need any more convincing, I'll just point out, right, the general screen or buttons, the knobology of a Sonocyte M Turbo versus like a typical echo machine. And you'll see the buttons that I'm able to use are also completely different. So for example, I think Sam had talked about, right, our time gain constant, like being able to manipulate the gain by levels. On a Sonocyte, you get near and far, that's it. On the actual ultrasound or echo machine, you can manipulate it literally like centimeter by centimeter, which again, improves the resolution of your picture. You also have the opportunity to do things like manipulate the focal length, which we can't do on a Sonocyte. All of which to say that actually, I think that image optimization is even more important in PoCUS because you don't have the ability to manipulate it afterwards. It's like using a like cheap camera versus like an expensive camera and then post-processing in like Adobe. If you can manipulate the picture afterwards, then it kind of doesn't matter what you take in the moment because you can make it look good afterwards. But if you can't, then you have to make sure that you're getting a good picture to begin with, which is why I think it's actually important for us to be really good about trying to get the best image by doing or using the best technique. Okay, so the views, these all come from standard echo views. They just are not manipulated in the way that Peds Echo does, where we flip the screens. So the first one, and different places will have different protocols, but Eric and I have talked about this. And in general, I prefer to use the subcostal first because I think it gives us a lot of information that will help really quickly and also with the rest of our exam. And so for all of the views, we're going to do quick through anatomic position, which is like where we put it on the patient, the indicator position, and then what you're able to see in 2D, Doppler, and measurements. So with the subcostal, you're going to do subxiphoid and slide about 2 or 3 centimeters over to the right, but point it at the left shoulder. And the indicator position should be at 3 o'clock. So if you are right-handed, and I am right-handed, I tend to hold it overhand, and the indicator will be like under my middle finger. And with that, you are slicing the heart essentially in its or through its long axis, but like from the bottom. So you get what looks like a 4-chamber view, like this. And so all the structures are clearly labeled, but you can see all 4 chambers, right? The valves that lie in between the chambers, so your tricuspid and your mitral valve. And then you can sometimes get your great vessels like your SVC and your IVC. This is a great view to look at your atrial and ventricular septal defects because they are perpendicular roughly to the probe. This is your atrial septum. This is your ventricular septum. And you can also get gradients across in terms of ASD and VSD gradients. But going back to what I was saying originally, and the reason why I prefer to start with this is that it gives us an idea of visceral situs. So if you are levocardic, which most people are, then you can go and do all the views the way that you would do them. But if you have dextrocardia and you don't know that, then if you start with something like a parasternal, you're not even going to be imaging the heart because the heart isn't on that side of the body. And there's no way to know that unless you were to someone either telling you or you figure that out by doing something like a subcostal. So this allows you to say, okay, the heart is on the left side of the chest. The stomach is on the left side of the abdomen. The liver is on the right. And so I just think that it's easier to start this way. We can also from here, because we see all 4 chambers, get a quick assessment of qualitative function, as well as looking for both pericardial and pleural effusions. And if someone is on ECMO, because you can see the IVC and SVC, you can also get an idea of where the ECMO cannulas sit. So what I'm going to do now is try to move to this Toronto website. Can everyone see it? Because I don't know what people can see.
Looks good.
Great. So I love this website because it tells you where the probe is relative to the structures in the body. So this is a subcostal, and if I rotate it, you can see this is how it cuts through. And so it'll make the images that you get more, I think, like easier to understand. And if you just Google Toronto ATE, you'll be able to find it. So yeah. All right. And then for the rest of these, I also have gone through and put a Sonocyte PoCUS image on the left and then the echo version on the right, just to give you guys a comparison of what the image quality might look like and how it might differ. So with the subcostal, you'll see that the image quality is actually fairly similar, and a lot of that has to do with the acoustic window that the liver itself provides. But these are, again, fairly similar. I would say that the one on the right is not optimized in a way that we had talked about before, where your heart takes up the whole screen. But other than that, similar. All right. Okay. From the subcostal, where you get all 4 chambers, we can move into the subcostal IVC view. So you're just going to take your probe from where it was with the indicator at the 3 o'clock position, my fake probe, and then turn it this way and move it slightly over to the right, since your IVC is on the right side of your body. From there, you are basically able to see the IVC coming into the RA, as well as the hepatics joining the IVC before they come to the RA. I don't typically Doppler anything here, but this is where one would do, if they were doing like adult PoCUS, would do your IVC diameters for IVC compressibility or distensibility, and you can do the M mode through the IVC. So again, using the Toronto, move over here. So that's where we had placed the probe. And then if you turn it, or should it turn the other way? You'll see it cuts through RA IVC. So that's RA IVC. Again, here. And again, comparison of the 2 different imaging systems. They're pretty comparable using the liver as the acoustic window. Okay. So from there, we're going to move on to your personal long, which is where many people prefer to start their cardiac PoCUS and where a lot of echo labs also start the protocol. So here, we're going to place the probe to the left of the sternum, somewhere between the third and the fourth ribs. The indicator should be pointed towards the right shoulder, 10, 11 o'clock, which will allow you to slice. Again, this is like kind of hard to understand unless you have done it or have seen it, through the long axis, which is this axis of the heart. And before we get into the structures that we're going to visualize, I think maybe it's helpful to go back to the Toronto page. So again, that you can understand how it's cutting through the heart. Okay, so, right, the sternum would be lying over here or to the left of it, second and third rib. And you'll see that it cuts through the long axis like that chest x-ray picture I showed you on the second slide of the heart. So from here, we can see a number of different structures. We see the RVOT out this way, and if you stoop up, you'll see more of it. The aorta, the LVOT, the mitral valve, the papillaries, and then LA. So this is a good one. If you want to do Dopplers, you can do Dopplers across the LVOT, across the aorta, and then the mitral valve. It's not the best for that because now those that blood flow is moving this way, and if your probe is coming this way, it's actually perpendicular, but you can do it. The things that it is better for are the 2D structures, which are perpendicular to it. So like a VSD, this is a good place to get a VSD shot, a VSD gradient, and you can always see pericardial and pleural effusions, pericardial more than pleural, and you'll tend to see them as posterior pericardial effusions because, again, if the left side is the more posterior structure, this is the left side. So we're going to see fluid accumulation back here. On the left, again, PoCUS on a sonocyte. On the right, an actual echo performed on a standard echo machine. The quality is okay on both. And you'll see that there's actually a lot of dropout on the left side of the screen, which may be due to like rib shadowing. Ideally, when you're doing this image, you should also try to put the aortic valve basically in the center of your screen. So that's the aortic valve. That's the aortic valve. Okay. From here, you can both sweep or tilt up and down, which will get you different parts of your personal long and get you different structures. So the tricuspid view, which again, right, the AV valves are posterior relative to their semilunar valves. So if you're trying to get tricuspid, you need to make sure that your probe fan or like the plane that you're getting is going deeper. So you want to tilt your tail up to get the probe like deeper into the patient, and the beam will go down. So if you do that, you end up getting the right ventricle, tricuspid, and right atrium, as well as the coronary sinus. And then you can get a good tricuspid Doppler here if you're concerned about regurg or anything like that. Conversely, if you tilt the tail down, right, then the beam is heading up. And if you do that, then you get the RVOT and the pulmonary artery. And so from there, you can do Dopplers across the pulmonary valve, and even sometimes you can get branch pulmonary arteries. From there, we're going to move on to the personal short, which the way that I like to do it is I like to go back to that first view where you have the aortic valve right in the middle and take it. And sometimes I'll even stabilize it with my other hand and just rotate it so that the indicator moved from the left shoulder or the right shoulder to the left shoulder. So now it's roughly at like 2 or 3 o'clock. Again, I think it's better if we understand how that cuts through the heart. So going to Toronto. Starting here, right? The probe is in a similar place, but the plane is completely different because we've rotated it about 90 degrees from before. And it cuts through what I like to call, or some people call, the crux of the heart. In this view, they're doing it lower. But in the view that we typically start with, you literally go through like all the major structures and the aortic valve. So you end up with this Mercedes sign, which is the aortic valve, and then the left atrium below it. Usually you can see the right atrium, you see the tricuspid valve leading to the RV and RV outflow, and then the pulmonary valve. And they all make like this circle around the aorta. From here, you can get decent Dopplers for the tricuspid and the RV outflow because the flow itself is relatively parallel to the beam, right? If the beam is coming out like this, and these are each of the rays, then this beam is parallel and this beam is parallel, and that's the tricuspid valve and the pulmonary or RVOT. You can also do Dopplers, not really through the aorta, but if you put the Doppler on, you can see if there's aortic insufficiency. You just put it right over here. Measurements, again, TR, PI, and then if there's any effusions, they would be posterior effusions, which would be behind the left, maybe the right atrium. So I think here is where you start to see that the ultrasound, like PoCUS machine, is starting to become more and more inferior to the actual echo machine. Still have a lot of dropout here on the left, which is the right, and the imaging quality is just, I think, better here. In the parasternal, you can also further sweep to get more imaging of the LV itself, including the mitral valve and the papillaries. So if you just start where you did at the aortic valve with the Mercedes sign and continue to tilt your tail up, which means that your beam goes down further and deeper into the patient, then you'll basically cut the LV through multiple cross sections. And the views that people like to stick with are the fish mouth view, which is the mitral valve view, where you can see the leaflets of the valve. And then if you go deeper, you see the papillaries. Going specifically into these different views. So in your mid-papillary view, obviously, you see the papillaries. This is a good place to get your M mode, which is you're going to want to do right here through that. And it basically in M mode in 2D shows you the contraction of the LV over time. This is also a great view to get any idea of if there's original wall motion abnormalities, because it is, the LV should be a circle, right, concentric muscle. And if it doesn't all come together and release pretty uniformly, then you know that you have original wall motion abnormalities. And something that someone taught me, which I thought was really like just easy and quick, is if you cover different quadrants just like manually with your hand while it's playing, you can see if it's coming and contracting towards a center point. So here, again, two examples. The one on the left is not optimized in that the image itself has a lot of extra space at the bottom. The one on the right is better. One on the right is the echo image. They're similar-ish. I think the ultrasound, the echo image is still a little bit better. And this is a mid-papillary view. Okay, now we're going to change. So the views that we've gone through before, just so I make sure everyone's on the same page. We did a subcostal, which is one of the major groups. And we did a parasternal long, which is one of the major groups, and then a parasternal short, which is the third major group. So the last major group is the apical views. We start with the apical four-chamber. And this one is sometimes hard because, one, depending on the patient's like body habitus, it can be hard to get. But two, where the apex is different depending on what or who the person is. So I find that the easiest way to do it is I feel for the PMI and then I just start there and start sweeping or sliding around. So I go towards the PMI. The probe is, again, I'm holding it overhand the way that I would with the subcostal view, and the indicator is at the 3 o'clock position, which means it's like under my middle finger. And then I want to aim it towards the right shoulder because, again, if the axis of the heart is like this, we're trying to catch it like up its axis. I think I have a picture of that. Yeah, like that. Moving back to Toronto. So your probe is here, you're cutting it straight through. So when you turn it, you see all the structures as such. So you see all 4 chambers and both of your AV valves. The best way to optimize this image is actually, and like if you're using for calculations like symptoms for EF, is to have the septum pretty much be in the center of your screen. So if this is your intraventricular septum, ideally it would be like here, but this is pretty good. But you want to try to avoid having it too far out or not even being at the apex, because then you risk foreshortening the picture, right? If you were to catch the ventricle here versus here, then you would be misrepresenting the geometry of the LV, and therefore miscalculating the EF, which is ejection fraction, which is a bullet that you have to, the machine will do the math for you. Other things that are good from here, because your AV valves are oriented perpendicular to your probe, and this means that the blood flow that rushes through it is parallel. So this is a great place also to get your mitral and your cuspid valve Dopplers. It's also a good place to get your TAPC and your MAPC because tricuspid valve, mitral valve. And we can see things like pericardial effusions and tamponade physiology. So in tamponade physiology, you'll see like buckling of your RA and your RV, and you'll get different inflow gradients or variability across your mitral and tricuspid valves. So we won't go over that now. So comparison again. They're kind of similar. I would say that the one on the right is foreshortened because now the heart, instead of looking like a nice long structure, looks kind of globular, which means that you're cutting it shorter than the apex. And then the other important thing that I forgot to mention earlier is in both of these, you see this hazy structure that moves in and out of the screen from the right, and that's the lung. So that's another good reason why I like to start with something like the subcostal, especially when it comes to quick assessments of function, because the subcostal is imaged through the abdomen, which means you don't have to compete with other lung or thoracic structures like lung. And in situations where you have patients on ventilators with high settings, or maybe you're on an oscillator, right, the lungs can really get in the way and impact your ability to visualize the heart, especially because lungs are full of air, and air refracts and reflects light like all different angles. It just like, it can make it quite a mess. But if you go through the liver, then you're always going to get, thank you, a good image. All right, and moving on to the 5-chamber. So here we start roughly at the same place as the 4-chamber, but we take our tail and we tilt it down even more. Because as we said before, your semilunar valves, which is your aortic and your pulmonary, are more anterior than your AV valves. So you want to get higher up, like in the heart. There's no 5-chamber in the Toronto, so I can't show you. So from here, you see the same structure that you see in the 4-chamber, plus the additional aortic view, which allows you then to do aortic Doppler and measure the aortic VTI, which gives you an idea of how much cardiac output there is. And then finally, within our apical views, there's the 2-chamber view, which is necessary if you're doing a Simpsons or a calculation of EF. So we go back to the original view where we had the 4-chamber, and now you just take your probe and you rotate it in your hand so that it's roughly 45 to 90 degrees from your previous, and you're cutting the LV like through this way instead of through this way. And your indicator usually would end up in the 12 o'clock position. From here, you basically only see the left side of the heart, so you see LA, mitral valve, LV, and then you can get Dopplers through your mitral valve as well as the other calculations for your Simpsons for your ejection fraction. And that's it when it comes to views.